Um, Hi, good afternoon, everyone. My name is KK Yo from the National Heart Center, Singapore. Welcome to this APCMC, APSC joint webinar on key updates from the American Heart Association meeting earlier this year. With me co-chairing this session is Professor Steve Nichols from Monash, Australia. And today we have with us three speakers sharing a little bit about what was presented at the American Heart. And they are Dr. Lee Yi-Heng from Taiwan, Dr. Himanshu Gupta from India, and Dr. Gao Xiongyi from China, Singapore. He's doing a research attachment in Singapore. And without further ado, let me welcome Professor Lee. Professor Lee will present on the study that was presented at the American Heart Association meeting. But before I do that, I just want to quick thank you to the Taiwan Heart Foundation for supporting this educational event. Thanks very much to our friends in Taiwan. So over to you, Dr. Lee.
Yes, good day, everyone. Can you hear me?
Yeah.
Yes? Okay.
Yes.
So I was assigned to present the first in-human trial about the oral PCSK9 inhibitor. The compound's name is MK0616. So this abstract was presented in this year's AHA meeting. Here's my disclosure. So I think I don't have to explain the pharmacological mechanism of the PCSK9 inhibitor right now. Everybody understand this mechanism. So far right now, we have 3 injectable PCSK9 inhibitors right now. So we have 2 monoclonal antibody. The one is the Repasa and the Praluent. So right now we are having another small interfering RNA that is the Lecuvia. So these 3 are injectable drug for the PCSK9 inhibitors. I think everyone, just like me in Taiwan, we are facing 2 problems about these drugs. The first one is the uptake of the injectable drug is very late because the patient maybe are reluctant to receive the injection drug, and most of patients prefer the oral form. Another problem of this drug is maybe the price. The price is so high, so most of patients cannot afford to receive the PCSK9 inhibitors. So currently in the market, there's no oral PCSK9 inhibitors. So the scientists in the Merck company, they use the most recently developed the biotechnology and the screen, and they found one peptide, the cyclic peptide, that can have the PCSK9 inhibitor function. So you can see the figure here that this peptide can block the PCSK9 function. So the right side here is the chemical structure of this cyclic peptide. So the compound's name here is the MK0616. So in the preclinical studies, they found this MK0616 has very high affinity against the human PCSK9. So this peptide is chemically stable and resistant to the GI degradation. So this peptide, I think they can be used to develop oral form PCSK9 inhibitors. However, this peptide, they need an enhancer to enhance the GI absorption. So the enhancers, the compound's name they use is lebrozole or the caprate. So in the initial preclinical toxicity study in the animal, they found this compound, they use the subcutaneous injection or oral form. There is a very little toxicity, and there's no observed adverse effect up to the highest tasted dose. So in this study, they performed the phase 1 clinical trial. That is the first in human trial of the this polypeptide, the MK0616. So here is the first phase of the phase 1 this is the phase 1 of this clinical trials. So in this phase 1 study, they included 60 male patients, and they only received a single dose of the MK0616, but with different dose from low dose to the highest dose. The key question they want to answer in this the phase 1 trial is about the toxicity and the safety of the MK0616. So the dose they use is from 10 milligram to 300 milligram. They also want to understand the pharmacokinetic of the MK0616 that include the effect of the enhancer dose on the pharmacokinetic, the effect of food on the pharmacokinetics, and the target engagement of this phase 1 trial is about a change of the free PCSK9. So on the right table here, you can see here that they include about 60 patients. The age is from 18 to 50 with a mean age about 38 years old. And most of them are Black or African American. So in the very initial phase 1 trial, they found there's no deaths and no severe adverse events. About 6 out of 60 patients discontinued the drug. So all the treatment-related adverse event was very mild. And the adverse event report by the investigator is only a very mild abdominal discomfort, diarrhea, headache, or a rash. And for the laboratory data, it shows the compound is very safe. And there's no change of the patient's vital sign or any ECG change. So here, the figure shows here is the pharmacokinetic data of the dose. We have to remember that in the phase 1 trial, the patient only received one single dose. You can see they found that the enhancer they use, including the Labrazole or the Caprate, they can improve the GI absorption of the MK0616. If you don't use the enhancer, there will be about only half of the GI absorption. There's no influence of the enhancer about the PK level. And a very important thing is that there's a negative food effect on the MK0616. That means even if you use the enhancer, if you take the food before the drug, you will be about half influence the GI absorption of the compound. So here is the phase 1 trials result. Here is the percentage reduction from the baseline of the free PCSK9. So you can see the tested dose from 10 milligram up to 35 milligram per day. The single dose of the MK0616 is a very effective. You can see the upper line here is the placebo. So after taking the dose of the MK0616, almost 90 to 100% inhibition of the free PCSK9. So it's the compound is very, very effective in inhibition of the PCSK9 inhibitor from 10, 35 to 100 milligram about the MK0616. So they proceed into the phase 2 of the trial. So in this phase 2 trial, it's a randomized placebo-controlled study, and they randomized the patient to receive the different dose of the MK0616. They test a different dose, 10 and 20 milligram, or 10 milligram with different enhancer, and they also test the food effect with 10 milligram, and before the dose, the participant took the food. So you can see they include about 40 patients, about 27 male and 13 female. The mean age is about 58 years old, and all of them were white. And you can see that about 85% of these participants already were taking a moderate to high intensity statins. So the first result is also the safety outcome. there was no death, no severe adverse event, and no discontinuation of drug. So in this phase 2 trial, they received the MK-0616 for once daily dosing and for 2 weeks. And all the treatment-related adverse events were very mild or only moderate. So you can see the reported adverse event here, including the dizziness, dry mouth, the hunger sensation, decreased appetite, insomnia, or the gastroesophageal reflux. So you can see this is only a very mild to moderate adverse effect. And very similar to the phase 1, to the first trial, that there's no change of the vital sign or any ECG change. So here is the result of the phase 2 trial. You can see the reduction of the LDL. So you can see the vertical axis here is the percentage change from the baseline. So the line here with the square box here is the placebo. The second line here is the dose with the 10 milligram MK-0616, but with the meal. And the other 3 line here is the dose from 10 to 20 milligram MK-0616. So you can see after 14 days treatment of this compound, you can reduce the LDL up to almost 50 to 65% of the LDL reduction. So this phase 1 trial shows that this compound is a very promising drug that can use to reduce the LDL. So the summary is here that the MK-0616 was generally well tolerated up to the dose of 300 milligram. However, you can see the dose from 10 milligram up to 300 milligram have almost the same effect. So they test only 10 to 30 milligram in the second half of the clinical trial. So the MK-0616 is very safe. There's no death, no severe adverse event, and no significant change of vital sign, the ECG, or laboratory examination. So the MK-0616 can reduce the PCSK9 up to almost more than 90%, and also cause a reduction of the LDL about 65% after 14 days treatment. So the conclusion of this, the phase 1, the first in human trial of oral PCSK9 inhibitor is that this phase 1 trial are very encouraging and showing oral PCSK9 inhibitor also can significantly reduce the LDL on top of the statin treatment. And as an oral PCSK9 inhibitor, and the MK-0616 has a potential to be a highly effective cholesterol lowering agent for patients that need the LDL reduction therapy. So such a medicine probably may overcome the barrier of the current treatment we have and allowing more patients to achieve the LDL goal. And additionally, we still need a larger clinical trial to evaluate the efficacy and the safety of the MK-0616. Thank you very much for your kind attention.
Thank you, Dr. Lee. So it's really provocative results. Thinking forward, we're now got 3 different approaches to targeting PCSK9 monoclonal antibodies, RNA interference, which, so there are differences in terms of injection regimens and those types of things. And now you have an oral. If we get to the end of all of this, what do you see the therapeutic landscape looking for, like, in terms of which of these you use?
So, Steve, can you repeat your question again?
I'm just wondering that in a world in the future where there may be 3, if not more, ways to inhibit PCSK9, where do you see these oral medications kind of sitting in that landscape compared to the injections?
So actually, there is a panel discussion after the presentation of the scale. I think there are several points, many experts indicate. The first one is, of course, the price. The price has to be a little bit cheaper than the current injectable drugs. And the second one is that as I mentioned before, most of the patients still prefer the oral drugs. So they do think that if this compound can have a very smooth and successful development later, so once daily oral drug still is more to be preferred by most of the patients. And the third point is that we still need a cardiovascular outcome trial of this kind of drug to show it's a real clinical efficacy on the hard endpoint for our patients.
Yeah. So I wonder if the biggest challenge here, I mean, yeah, I completely agree with all of that. And at the end of the day, I think that if you have an agent that lowers LDL cholesterol by more than 60%, if you conduct the right outcome trial, it will work. But I guess just as importantly is understanding safety and tolerability. And do we know much about these absorption enhancers in terms of other therapeutics?
So far the data right now just showing that the enhancer, including the two enhancers they choose, they don't have significant influence on the pharmacokinetic of the drug.
Yeah, and you did show early data showing that about 10% of patients developed a maculopapular rash. Were they?
Yes.
Did they give more information with regards to those rashes? Were they minor? Were they more severe rashes?
I think the speakers, the scientists from the Merck company just mentioned about the rash, and they think it's a mild adverse event, and they just go away themselves.
Right. Okay. Well, I think that this is the first foray. That there have been other attempts to develop oral PCSK9 inhibitors, and none of those other programs have got to this point. So I think many of us were quite intrigued and excited to see what an oral PCSK9 inhibitor could do, and certainly what we've seen so far looks really encouraging. We await to see what the next steps look like in terms of bigger trials, and I agree with you. I think that the ability to bring a small molecule oral formulation to the clinic, if it is considerably cheaper and well tolerated, will provide a really important opportunity, and see how that fits into practice.
Yeah, personally, I think there's still a long way to go. Yeah, it's only a phase 1 trial, and one more benefit if this drug can be developed successfully and without a further side effect of this peptide. I think one more benefit is that it can overcome some of the statin intolerance, the patient with statin intolerance. Yeah. Like some of the patients still have complain about the muscle myalgia. So if the problem can be developed smoothly, I saw that this will be another benefit of this compound.
Agree, and I think that if you look at the PCSK9 inhibitors, we now have we presented data for a CETP inhibitor at AHA that had 50% lowering of LDL on top of a statin, and you start to think we're combining therapies together, which should get most patients to an LDL cholesterol level that we're kind of aiming for in the clinic. So I think the future is bright. So on that note, I'd like to thank you for kind of updating us on oral PCSK9 inhibitors, and we'll move on to the next speaker, Associate Professor Gupta from India, and he is going to update us on a study across a diverse healthcare network of 10,000 patients, and really looking at a program of cardiovascular prevention targeting multiple risk factors, but from a remote perspective, and that's certainly something we've all had to embrace over the course of the last 2 years, and I'm very much looking forward to hearing about this today. The floor is yours.
Good morning, everyone, and thank you for the kind invitation to be part of this wonderful session. I'm Dr. Gupta. I'm an Associate Professor of Cardiology in a government hospital in North India. So I've been given the task to present this very, very fascinating study presented by the Mass General Hospital and the Harvard Medical School of digital care transformation, a report of the first 10,000 patients enrolled in a remote algorithm-based cardiovascular risk management program to improve lipid and hypertension control. Yeah.
Sorry to interrupt. You might want to share your screen, and could I also ask that you maybe just speak up a little bit more? But do share your screen. So I think it didn't come through.
You can't see my screen, Prof?
No.
No.
Okay.
So while you bring up the screen, we'll let you know when we see. There it comes. Great, thanks. Just put it to presentation mode, and yep, we'll let you carry on from there.
Perfect.
Go ahead.
Yeah. So thank you so much. Yeah. So I just present a very fascinating study from the Harvard Medical School about first 10,000 patients, which they enrolled in an algorithm-based risk management program to improve lipid and hypertension control in the community. So these are the author disclosures for the study. So as we know that undertreatment of hypertension and dyslipidemia is a persistent clinical challenge which we all face across the world. About 30 to 50% of the patients in all of our practices do not receive optimal medical treatment, even though most treatment options are generic. That means that most of the treatment options in most of our countries now are very cheap and affordable, and some are even reimbursed by the government. But still, almost 50% of the patients do not receive them optimally due to lack of knowledge or lack of proper follow-up. The shift towards the remote health has the potential to revolutionize care, but raises concerns for deepening the digital health divide. Thus, there can be some countries which are very good at it and some countries which are not that good at it, depending upon where they are in their digital platforms. So this group of researchers from the Harvard Medical School developed a program to address these gaps in care. So the aim of the program was to enroll patients who were referred for dyslipidemia and hypertension to the hospital, and they started enrolling patients before January 2018. So the patients were identified by the referral and electronic health records, screening for hypertension and LDL cholesterol to achieve recommended guidelines. So there were few exclusion criteria for the lipid arm and exclusion criteria for the hypertension arm. So the patients in the lipid arm who were pregnant or were planning pregnancy or breastfeeding or had a stage 5 CKD were excluded from the lipid arm. Whereas in the hypertension arm, any patient with severe aortic stenosis, renal artery stenosis, or heart failure reduced ejection fraction were excluded for obvious reasons. So the hypertension management was enabled by the Wi-Fi, cellular, and Bluetooth devices. And no patient had to bear any additional costs to be part of the study. So it was well funded by the government and its, by the hospital and its accessories. So there are three spokes of this model that they have shared. So the three main partners of this digital health program were the patient navigators, the pharmacists, and the digital technology. So the patient navigators were the main workforce for the field. So they were non-licensed, high contact model, motivated individuals who were provided education and who gathered all the data. The pharmacists were well trained. They were working in collaboration with the navigators, and they were the ones who were doing the up titration or titration of the drugs which the patients were taking, or at appropriate time, these pharmacists could refer the patient to a physician, a MD, or a super specialist physician based on their discretion. And digital technology, as we know, was also the very important part of this program. So out of all the database that they had before enrolling, so the patients who had problem in their blood pressure control or lipids control, they screened about 28,000 patients, and about 20,400 patients were eligible for the screening, and they could finally contact 18,000 patients. And before January 2021, they had enrolled 10,000 patients already in the study. So out of these 10,000 patients, 9,547 patients were eventually put into two arms. So the lipid arm had about 6,800 patients and the hypertension arm had about 3,300 patients. So out of the lipid arm, that is the 6,800 patients, the patients who required active titration of the drugs, that means change in drugs or addition of drug or change of dose, they were about 23%. And finally, 40% of the patients out of these 6,800 patients were in the maintenance arm. So with this digital contact of the patient and enrolling of the pharmacists on board, they could have 40% of patients in the maintenance arm in the lipid program and 44% of the patients in the maintenance arm in the hypertension program. And in the hypertension program, around 15% of the patients required active titration of the doses. So rest 37% in the lipid arm and 41% of the hypertension arm were not enrolled as part of the maintenance because either they were unreachable every time, or they withdrew, or they were referred to a super specialist for titration based upon a outpatient clinic visit. So the baseline characteristics of the patients. So the baseline characteristics, if we see that about 12% of the patients were very elderly, that is age more than 75 years, 55% were females, 29% were non-white, and what is very interesting, around 8% of the patients were non-English speaking. So here we are talking about a study where language is everything, but here we see that about 8% of the patients were non-English speaking, and we will discover later that their outcomes were as good as the English speaking population. In the lipid categories, they had established atherosclerotic vascular disease in 29%, diabetes alone in 22%, LDL of more than 190, that is very high LDL in almost a quarter of the patients, that is 26%, and they were high risk for primary prevention, the patients about 23%. So very high risk subgroup of patients. So a total of 100,000 phone calls were made, 400,000 in addition to 400,000 blood pressure values were taken, 74,000 lab evaluations were done, and 27,000 new prescriptions were done. So a lot of work was done over this period by the three spokes of the program. So here we see the all enrolled patients and the patients who achieved maintenance. We see the chart of the systolic blood pressure and the diastolic blood pressure. So we see the qualifying systolic blood pressure was about 150 millimeters of mercury, and qualifying diastolic blood pressure was about 84 millimeters of mercury. So if we see all the patients enrolled in the hypertension arm, that is 3,367 patients, eventually they could have a difference of 10 millimeters in the systolic blood pressure and 6 millimeters in the diastolic blood pressure by enrolling in the arm. But if we look at the patients who achieved maintenance, that is about 40% of the patients, they had a difference which was significantly more, that is 12 millimeters of mercury in the systolic and 7 millimeters in the diastolic. So all these differences were significant. And these significant differences were same across races. So they were similar in whites, blacks, and other races, Hispanic, and similar in non-English speaking as well. So all the differences in systolic and diastolic blood pressure, which was significant, which they achieved in the study just with closed digital monitoring, were similar across age groups, across all the races enrolled in the study, and also even for non-English speaking patients. So if we come to the lipid arm, so if we see the all enrolled patients, that is about 6,800 patients, the difference in LDL is significant. So 145 versus 100. And the patients who achieved maintenance, that is about 2,700 patients, that is after titration based on the digital records and pharmacist intervention. So in that we see the initial LDL was 140 milligrams per deciliter versus in the end they achieved LDL, which we all desire for our patients of 70, which is excellent. In the lipid arm, as it was in the hypertension arm, the effects were significant across all races and across all languages. And this slide, I think, is very interesting of that what kind of intervention was improved or increased after they were enrolled in this digital program. So we see that about 40% of the patients were on high statin initially, but after they were enrolled into this digital healthcare and close follow-up, almost 55% of the patients were on statin. So 15% more patients received statin, that is high dose statin. In the ezetimibe arm, we see 9% of the patients received this additional LDL lowering drug initially, whereas 20%, so every fifth patient received ezetimibe, which is also quite significant and quite alarming. And PCSK9 inhibitor use has also increased 500%. So it was 1%, and in the maintenance arm, it was almost 5%. And which is also very interesting that almost 20% of the patients, despite having lipid issues, were not on any medication before they were enrolled in this digital program. And that number was 3% at the end of the maintenance arm. So significant differences in treatment were undertaken as part of the study without any contact from a specialist doctor. So without increasing the burden on the outpatient clinic or on the hospitals. So in summary, a remote algorithm-driven management program was very effective to improve hypertension and lipid in high-risk patients. It reduces the need for in-person visits and physician time, highlights the persistent challenges for longitudinal care, and delivers equitable remote care across traditionally underserved populations, whether geographically or in terms of education. So in conclusion, this program of digital health monitoring and close follow-up has the potential to expand remote healthcare delivery, increase access to care, reduce health inequities, and improve healthcare quality. This research illustrates its performance in a learning health system. Thank you, and I must congratulate the authors for a very wonderfully done study. Thank you so much.
Thanks, Gupta. That's a really nice overview of the study as presented at the American Heart. So some thoughts and some questions. The study was performed in Massachusetts in the US, a wealthy country. I would have hoped that we could do something like this in perhaps low and middle income countries where access to such technologies, or rather access to medical care in general, may not be so easily available. Looking at you as you did on the study design, do you think that it can be replicated, say, in India? Would it be possible?
Thank you, Prof. Yeah, I think it's a very important question that the digital health is probably the way forward. And even in our country, which is a middle income country, and it's geographically very wide, and many patients do not have access to super specialist doctors or large government hospitals. They have to travel a long distance to come, and also they have to spend a lot of money while traveling. So if they have to meet us in clinic, they will lose out work for 3 to 4 days, 5 days to just reach the hospital. So I think this kind of technology is actually tailor-made for countries like India, the Asian countries, which are very, very large in population. So all it requires is that we have to train these participants to be part of a program like this, have a trained pharmacy which can up titrate the drugs. And I think digital technology is already there. So even in India, the person who is very, very poor will still have a good smartphone where he can receive messages, emails, WhatsApp. I think that technology has percolated really well. What is lacking is the trained pharmacists who can modify the drug dosages, and volunteers to be part of these kind of programs. But I think if these kind of programs can work, it can really, really change the hypertension and lipid management and so many other fields also. I think it is well suited for our country.
I think that's the hope, I think, and hopefully we can learn more from their processes. I just wanted to also make a point that one of the things which I didn't see in that presentation is the cost of doing such an intervention. Of course, in this case, the insurers and the healthcare system paid for this enrollment. But even so, I think only 40% of patients roughly were able to stay on the maintenance program. And I think it'll be important for a health economic analysis to see what the cost would be to train what was it, the concierge, or what was the term used, the facilitator, and also the pharmacist, because these services do not come cheap. And I see Steve nodding your head. Maybe Steve, you have a comment?
Yeah, it's great data. The two things that kind of came to mind to me were, one, did they enable for the concierge to actually be able to use diversity in what they were actually able to do for these people? Because I think, their conclusion talks a lot about equity. Well, going out to different people involves delivering messages different ways and kind of interacting with them in different ways. And did they talk much about the nuts and bolts of how they really did this?
Yep. Steve, actually, all the methodology, the details of the methodology and the pricing were actually not available to us, because they have not published this article yet, and they've not published all the details, but we could just get the slides and around whatever we could find.
I think the other thing that would be really interesting to see from this group would be, I would really like to see what these results looked like in that kind of period of time when they weren't doing this. So if they were to take 6,000 people into a lipid program and 3,000 people into a blood pressure program, and followed them for that kind of period of time, would they see the same types of improvements? Would they see better improvements if they did it the way they used to do it? Would they have seen worse improvements? And so I think there's some really interesting other ways of looking at the data, and they should be able to look at their electronic health records to be able to look at potentially, the 2 years immediately prior to having to do all of this. And I think that would be really informative in its own right.
Yeah, I think. Go ahead, Dr. Gupta.
Yeah, just the concern that I had when I read this study was that the pharmacists were doing significant intervention, like the PCSK9 use increased almost 500% in the study. Ezetimibe, a new drug, was added. High dose statins were added. I'm not sure in many countries, like in my country in India, I do not think that a pharmacist can add a new drug without a doctor, actually signing it. So because if there is a side effect of the drug or anything happens to the patient because of that drug, then so many other medical legal issues come in. So I don't know how much power the pharmacists have in a particular country to be part of a program like this.
That's a really good point. And I think in the United States, you have nurse practitioners, and I guess in the context of this program, the pharmacist was able to make some changes to the medications. I think we will need to see the details in the publication or speak with the the investigators. In say a country like Singapore, we do have certain scenarios where pharmacists can prescribe drugs or nurse practitioners can prescribe drugs, but as you described or as you alluded to, some of these privileges are dependent on the medical care regulations in each country. So probably this needs to be customized if it can be done. I would say that sometimes the cost of such interventions is very dependent on the different weights of different resources available. So if it is hard to find a concierge, then the concierge becomes expensive, and and relative to the cost of having a doctor do the work, it might just be cheaper. But again, I think that is a health economics analysis that the team would have to conduct and and share when the data become available. Steve, any other comments on your side?
I think that we're all trying to think how we can do things like this. I think we were trying to think about it before there was a pandemic. We've had to be creative and innovative, and even despite doing that, we know that we've missed a lot of people. And I couldn't agree more with KK. I feel that there are ways to do this as we move from the richest country in the world, to lower and middle income countries where we have an enormous challenge, but there are some opportunities, and maybe it's doing it slightly differently. But I think there's a lot to learn there, and I think many of us will be going away from this and thinking about, how we might be able to do it, in our own region.
Thanks, Steve,
I'm
and
sure
thanks. Sorry, Gupta, carry on.
Just last, I'm sure if some of our engineering colleagues meet us, they'll make an app for these medications. They'll say that, you just I will make an app for you. So every patient who has diagnosed hypertension or lipid, you download this app, and they will send you repeated reminders. What is your blood pressure? What drugs are you on? And they'll make a flow chart so the patient can do it themselves. So I think in this kind of an era, I think the app is the next thing. So everybody will have it on their phone, and they can just get a reminder. Yeah, it's 3 months. Get your lipid levels checked. What drugs are you on? You don't have muscle aches. You can have ezetimibe. Okay, tick mark. Take ezetimibe. So I think it can be an app-based feature.
Yeah, I think there are several companies out there that have tools that can facilitate such interactions, but again, there are anything that is involves patient data in the cyberspace, in the cloud, or on an app, has to clear a substantial amount of regulations in every country. So I think that is another domain of challenge that we have not even scratched the surface of. So I think we'll get there. But it's going to be quite a journey, I would say. But I'm glad that you are able to share the study from the American Heart Association meeting, because I think that's a very nice illustration of what can be done. We'll still have to fine-tune things like cost and cybersecurity, but I think it's an important first step. So thanks very much, Dr. Gupta. Now it's my pleasure to invite Dr. Gao Xiongyi from currently at the National Heart Centre, Singapore, to give an overview or summary of the various trials in heart failure presented at the AHA, and he's going to try to compress and share 3 different studies, and we can then discuss them. Over to you, Dr. Gao.
Thank you, Professor Yu. Good afternoon, everyone. My name is Gao Xiongyi from China. I'm research fellow in National Heart Center, Singapore. My supervisor is Professor Yu. My presentation is about advances in heart failure therapy. Discussion from AHA 2021. There are 3 topics. Firstly, results from the Imperial Preserved clinical trial. Background, patient with heart failure present with either a reduced or preserved ejection fraction. SGLT2I reduced the risk of hospitalization from heart failure in patients with HFrEF, but their effect in patients with HFpEF are uncertain. The trial patient is more than 18 years old, NYHA function class from 2 to 4, and LVEF more than 40%, NT-proBNP more than 300 or more than 900 with atrial fibrillation. This is the trial design, and it's a RCT. After a screening period of 4 to 28 days, eligible patients were randomized assessed in a 1-to-1 ratio and in double-blind fashion to receive either placebo or empagliflozin 10 milligrams per day in addition to usual therapy. Patients were evaluated periodically at trial visits from symptoms, KCCQ, and adverse event, virtual signs, body weight, glycated hemoglobin level, antiprotein, EGFR, and the uric acid level were also assessed. The primary outcome was a composite of educated cardiovascular deaths or hospitalization for heart failure, aligned at the time to the first event. The first secondary outcome was the occurrence of all educated HHF, including first and recurrent events. The second secondary outcome was the rate of decline in the EGFR. This is the results. Total of 5,988 patients in two groups at 622 centers. The characteristics of the patient at baseline were similar in the two treatment groups. Nearly half of the patients have diabetes. 2/3 of the patients have a LVEF of 20% or more. The median LVEF was 54%. Then the trial medication was stopped for the reason other than death, more than 23% in two groups. 10.6% of the patients discontinued treatment owing to an adverse event. The median duration of follow-up was 26.2 months. This table is about the primary outcome. We can see the empagliflozin graph is better. This is the figure. Then we can see HHF in the empagliflozin group is significantly lower than the placebo group. The HR is 0.71. However, as the figure B, difference of the cardiovascular death is not statistically significantly between two groups. This is the primary outcome in subgroups. We can focus on the diabetes and the LVEF subgroups. The secondary outcome, the total number of HHF was lower with empagliflozin than with placebo. The rate of decline in the EGFR was lower in the empagliflozin group. Then from the figure, we can see all-cause mortality between two groups are similar. The safety, uncomplicated genital and urinary tract infection and hypotension were more common in patients treated with empagliflozin. The result about LVEF more than or equal to 50%. In HPV patient, empagliflozin reduced the risk of the primary endpoint by 17%. This result was mainly driven by the reduction in HHF. Time to the first event of HHF was reduced by 22%, and the total HHF was reduced by 17%. Empagliflozin produced meaningful improvement in KCCQ, CSS, and for NYHA class at week 15-2. Compared with placebo, empagliflozin increased KCCQ in HPV patient by 1.46 points. This patient treated with empagliflozin has a 34% 4% higher likelihood of being in a lower NYHA class. Conclusion, empagliflozin reduced the combined risk of cardiovascular death of HHF in patients with HFpEF, regardless of the presence of or absence of diabetes. Then, in patients with HFpEF, empagliflozin reduced the risk of primary endpoint by 17%. This benefit was driven by reductions in HHF. This is the first study that confirmed SGLT2I can reduce the risk of adverse event and improve quality of life heart failure symptom in patients with HFpEF. The limitations is the trial didn't appear to affect the number of deaths from cardiovascular or other causes. The possible reason is the percentage of patients who discontinued treatment for a reason other than death was more than 23%. The second trial is empagliflozin impact on health states, quality of life, functional states in heart failure, CHIEF-HF clinical trial. SGLT2 reduced clinical events in patients with HFpEF, but their effect on patients' health states, symptoms, functions, and the quality of life across the range of EF are less well described. Just prior to national COVID-19 lockdown, the CHIEF-HF trial was launched as a completed decentralized randomized trial without any face-to-face visits to investigate the effect of empagliflozin versus placebo on health status across the spectrum of heart failure, regardless of EF and diabetes status. Overview of RCT study design. Patient health status was measured with the KCCQ at randomization and at 2, 4, 6, and 12 weeks later. Data collection was performed remotely via a smartphone application, variable accelerometers, and throughout clamps. The primary outcome was change in KCCQ total symptom scores at 12 weeks, assumed using a mixed effect model of repeated measure, adjusting for treatment, stratification, time by study intervention, and the baseline KCCQ TSS. There are simple screenshot of the data collection app. The result is 448 patients included in the final analysis. The mean age was 13.4. The baseline KCCQ TSS was 58 in placebo and 15.7.4 in empagliflozin group. Empagliflozin significantly improved KCCQ TSS at 12 weeks versus placebo, with separation between the two groups evident at as early as 2 weeks. This benefit was consistent across the key pre-specified subgroups, include EF and type 2 diabetes. Conclusion, congamflorin rapidly improve the symptom of heart failure patient, regardless of EF and diabetes status. The highlight and limitation, although the design designed before the onset of the COVID-19 pandemic, the novel design of CHIP-HIVE highlights the urgency to explore novel approach to generating evident and possible benefit of innovative study design. The study sample size is relatively small, and the detailed blood test result and the imaging data could not be collected. Then the last trial is efficacy and the safety of empagliflozin in hospitalized heart failure patient, main result from the IMPALS trial. The empagliflozin reduced the risk of cardiovascular death or HHF in patients with chronic heart failure. Whether the drug is safe and improve clinical outcome when initiated in patients who are hospitalized for acute heart failure is unknown. This is the RCT design. IMPALS enrolled patient hospitalized with a primary diagnosis of AHF, who after clinical stabilization was randomly assigned to receive empagliflozin 10 mg once daily or placebo. The primary outcome was a clinical benefit at 90 days, defined as a hierarchical composite of time to all-cause death, the number of HF events, time to first HFE, and more than 2-point difference in change from baseline in KCCQ TSS, assigned using a stratified windshield. Results finally 530 patients who underwent randomization. Patients treated with empagliflozin with 36% more likely to experience a clinical benefit as compared with placebo. The win ratio is 1.36. The effect was consistent across all components of the primary outcome. All-cause mortality, HFE, and the KCCQ TSS. Empagliflozin was well tolerated with fewer serious adverse event and acute renal failure. Then conclusion, initiation of empagliflozin in patient hospitalized with HF resulted in clinical meaningful and statistically significant clinical benefits within 90 days and as well tolerated. The limitation is the study sample size is relatively small. That's all. Thank you.
Thank you, Dr. Gao. That was an outstanding tour de force, and perhaps it reflects how much heart failure therapeutics has changed. 3 really important studies, all with a class of drugs for heart failure that we would never have thought was something we'd be talking about 5 years ago. Maybe I can start by asking maybe about the last study you presented. Do you think that we now have enough evidence to support starting these agents kind of early, or do you think we still have to get more data before we can do that?
Sorry, Professor. The third trial.
So the third trial, which was about starting SGLT2 inhibitors early in acute decompensated heart failure. Do you think that supports us prescribing these agents earlier in more heart failure patients while they're still in hospital?
Yes, I think it's a good trial design. It tells us the SGLT2 I can use in the hospital, and but the number of the patient is relatively small. I think we can do more research about the amphotericin and the other SGLT2I. Yeah, do more research, can know more about the drugs.
Yeah, maybe we might ask some questions to the rest of our panel in regards to heart failure as well. Dr. Gupta, do you think there are some opportunities here for us to think about how we might be able to use remote management of our heart failure patients in a similar kind of model to what you looked at with regards to blood pressure and lipids?
Yeah, Prof. I think this digital technology can help all the fields of our practice, whether it's heart failure, whether it's coronary artery disease, because in our practice in India, the patient compliance is a big issue. Patient compliance and patient education is a big issue. The time a doctor spends with a patient in an outpatient clinic visit is also a big issue. Sometimes the doctor wants to educate the patient, but he's so busy in his clinic that he can't spend the time that the patient deserves. So I think a digital platform where somebody calls and asks how much liquid you are taking, how well are your sugars controlled, how well is your blood pressure controlled, are you having orthopnea, can you lie down flat, how much are you walking every day. I think these kind of things are very, very important, not just to add drugs or have new drugs, just to maintain compliance and to ensure that they are taking drugs. We see so many patients in our clinic, you won't believe, they will say that whenever we go out to eat, on that day we'll have the statin, but because that day we'll be having a lot of lipids, so we take statins, but on normal days we don't take statin, so they will have statin 2 days a week. So because they're not educated, and we also, when we see them in our clinic, we don't spend enough time with them as much as they deserve. So I think this can really help.
Yeah, and Dr. Lee, maybe I might kind of put a similar question to you in relation to early use of SGLT2 inhibitors in the heart failure setting in Taiwan. Are you seeing any sort of change in practice that changes that's kind of going on? And Dr. Lee may have left us again. Is that right?
Yeah, I think he stepped out.
Okay.
Yeah, for us in Singapore, the SGLT2 inhibitors, through the range of results, whether it's DAPA-HF or Emperor preserved, as well as reduced, it appears to work across many, the whole spectrum of heart failure, and has secondary benefits depending on where you look at or who is looking at it in the renal function as well. And the studies, as shown here with Emperor preserved and Pulse, suggest that it is a class effect when I say class, I refer not just to the class of drugs, but also class of conditions with heart failure. So I think it's increasingly being used very early on by both general cardiologists and heart failure cardiologists. And I think that's a good thing for patients.
And maybe I'll put a question to all three of you one by one for your view. I mean, in line with all of this and in line with the fact that we've got renal data, we've got some data here showing early benefits. Is this shuffling the order for heart failure therapeutics? And are we really starting to make a stronger argument for starting SGLT2 inhibitors a little bit earlier compared to, say, spironolactone or Entresto or agents like that? Do we think that this will become a more prioritized kind of class of agents? Dr. Gupta?
Yeah, Doctor. Thank you for the nice question. With this SGLT2 inhibitor, I always had doubt that whether the effect of the SGLT2 inhibitor is primarily out of the
I think we're starting to break up with Dr. Gupta's signal, so I might pass that question on to Dr. Gao. Do you think this data kind of suggests that we should be using these agents more preferentially compared to some of the other agents for heart failure?
I might maybe serve to translate a little bit. 问题是说哪一个药比较重要？用这个 SGLT2 inhibitor 或者用好像那些spironolactone 啊或者 Entresto which one will be more important in your mind to start first?
I think all drugs have its benefit, and but now the SGLT2 inhibitor is a new choice to us to use for a patient, and I think all of the drugs have its benefit. Yes.
Yeah, I agree, and I think that I think it's actually good for doctors and patients. It means we have lots of choices, and I think that when we move beyond the big trials that are in the New England, these other studies become really important because they help us to try and understand how we're actually going to use this when we've got a patient in front of us, whether they're sitting in a hospital bed or they're sitting in an outpatient room. So so thank you very much for presenting a number of really exciting studies today, and we really want to thank you for your debut performance with us on this webinar. So thank you for for leading us through that today. On that note, what we might do is we might draw Dr. Gupta.
Yeah, actually my connection got unstable. I'm so sorry I could not answer your question, Dr. Steve. So I was just saying that with the SGLT2 inhibitors, sometimes when we start them for a patient who's diuretic naive, what will be the effect? Because maybe the lot of effect of the SGLT2 is because of their diuretic effect. So there is no trial as of yet which has looped diuretics, showing mortality benefit in heart failure, because you can't design a trial of heart failure without diuretics on board. Now, so starting SGLT2 in a patient who is on diuretic in one arm and is on SGLT2 on another arm is an interesting concept, because we don't know whether it's a class effect or a diuretic effect. So that is my concern. And so, I am really, I don't start it as upfront but patients who are already on good class of diuretics and then as an add-on maybe, but so.
Well, and the other important factor obviously is the payer. And depending on, which health service you're in which country, you may not be able to use these agents early. And so again, I think that, we're all waiting in our various countries to see how the payer will play for all of that as well. So I think there are a range of patient factors and in addition to health service factors. So I couldn't agree more. So what I'd like to do is I'd like to thank our three speakers today. We've actually kind of really had a wide range of topics today. We've had an experimental drug for dyslipidemia. We've essentially got how a whole health service really reacted to COVID in terms of how to try to manage its risk factors, and really some intriguing thoughts for how we might be able to play that out in a whole range of other parts of the world, and I think we're all interested in what we can do in this region, and then a really elegant summary of the ongoing work in the SGLT2 inhibitor space. We've learned a lot about what it does in heart failure, and I think Dr. Gupta's last comment is spot on. We've got a lot more that we need to learn. So I want to thank our three speakers today. I want to thank my co-chair, as always, the Taiwan Society of Cardiology, for hosting us, and our partners for this webinar, the APSC and the APCMC team, kind of behind the scenes. So on that note, thank you for joining us today, and the Taiwan Heart Foundation, and enjoy the rest of your weekend. Bye.
Thanks everyone.
Right. Thank you.
Thanks.
Thank you.
Bye-bye.